Commonly, the cases of acute endocarditis will be caused by virulent organism like Staphylococcus aureus, whereas the subacute ones is commonly seen with virulent streptococci. Now, if you look at the pathogenesis, in the first stage, the organism gets access into the bloodstream. From there, it adheres to the damaged endothelium along with activated platelets. This results in formation of next vegetation. This vegetation is an accumulation of bacterial cells, platelets, and other blood cells like WBCs, and it goes on increasing in size, leading to progression of vegetation. And finally, in the last part, as you can see, this vegetation will end up destroying the cardiac valves itself, or it may get dislodged to form an emboli, may result in a cerebrovascular disease or stroke. Alternatively, the bacteria within this vegetation may multiply rapidly to form what is called as sepsis. So these are the complications of acute endocarditis. Now, I think in this picture you can see in this valve there are the vegetations. Now, if you look at the common etiologies of endocarditis, the most common causes would be Staphylococcus and Streptococci, followed by Enterococci, Pneumococci, and a very important group called as the HACK or HACK group of organisms causing culture negative endocarditis. Furthermore, the causative agent also varies depending on whether the native valve is involved or prosthetic valves are involved. Most of the native valves involvement will be by the Staphylococcus aureus. Similarly, intravenous drug abusers will be more prone for infective endocarditis, and they will have a different type of etiology, whether it's a right-sided endocarditis or a left-sided endocarditis. However, most common cause will be of the skin commensals like Staphylococcus aureus. Another important entity is what is called as the culture negative endocarditis. Now, what do you mean by culture negative endocarditis? This means when blood is sent for culture, the conventional organisms are not obtained. Most of the important causes of culture negative organism will include the HACK group of organisms, then Coxiella, Bartonella, Brucella, and Tropirema whipuli. Last but more important part of the infective endocarditis is the diagnosis. The diagnosis is done by modified Duke's criteria, in which we have the major and the minor criteria. The major criteria will have a definitive evidence of presence of organism either in the form of a positive blood culture or repeated blood culture, or a single blood titer for Coxiella burnetii positive for IgG more than 1:800, or we can have a echocardiographic evidence of vegetation. The minor criteria may include predisposing factors like IV drug abuse or immune compromise or fever, vascular phenomenon, immunological and microbiological phenomenon. Definitive diagnosis, when we have two major criteria or one major and three minor criteria or five minor criteria, we will classify it as a case of acute endocarditis. Similarly, now in acute endocarditis, the organism itself is directly causing damage to the cardiac tissues. Another phenomenon that occurs is the immunologic phenomenon. Let us look at another case. A 19-year-old male patient came with a chief complaint of abdominal pain along with joint pain for 3 days. He also noticed small red dots appearing in one leg. It disappears and again reappears. Other than that, the patient had gave slight complaint of uncoordinated movements, irregular uncoordinated movements. On examination, we can find small red colored dots on the leg of the patient. Other investigations are fairly normal within the normal limits. Now, how will you classify this case? This case would be a case of acute rheumatic fever. There is a definitive history of an antecedent sore throat infection which follows by immunological reactions. Now, if this pathology involves the cardiac valves, we call it as rheumatic heart disease. And if we look at the common presenting symptoms, we'll have migrating polyarthritis, pancarditis, subcutaneous nodules, syndrome chorea, and erythema marginatum. I think you will be most commonly aware of the pathogenesis of. Let us recapitulate the pathogenesis. During the episode of sore throat, the organism gets lodged to the pharyngeal epithelium. Over there, the toxin and antibodies are produced against the toxins and the parts of the streptococcal cell wall itself. Now, these antibodies will then cross react with various tissues and cause inflammation. Again, like modified Dukes criteria, we have a specific criteria for diagnosis of acute rheumatic fever, where we have a major criteria and a minor criteria. The major criteria would include all the 5 important like carditis, polyarthritis, chorea, erythema margitum, and subcutaneous nodules. The minor criteria will include all the features which do not fulfill the major criteria. Like we do not have an established polyarthralgia or polyarthritis, we have arthralgia or arthritis may be monoarticular. Or other would include fever, raised ESR or CRP, indicating inflammatory condition, or on ECG we have a prolonged period interval. Based on the major and minor criteria, we can classify whether this is an initial case of acute rheumatic fever where 2 major criteria, 1 major or 1 minor criteria will satisfy, or recurrent acute rheumatic fever. So, till now we have discussed about direct inflammatory process of the heart itself, that is pericarditis, myocarditis, endocarditis, and the immunological effect, that is acute rheumatic fever. Next part of the cardiovascular system would include the vessels. Now, the vessels would include the arteries, the veins, and the capillaries. Now, if we look at the inflammatory conditions of the arteries, we have 2 types, that is what is called as mycotic aneurysm. Now, please remember, although the word is mycotic, it is not caused by a fungus, rather a bacterial etiology which leads to destruction of the arterial wall, subsequently leading to swelling of the arterial wall. This is called as an aneurysm, and the infective pathology renders it naming as mycotic aneurysm. This is generally seen in the large arteries like the aorta or the larger arteries. Similarly, in the smaller arteries, we can have what is called as infective endocarditis, that is inflammation of the interstitial wall of the arteries. Now, looking back at the veins, very commonly, I think if you go to the ward, you can see many patients will have intravenous cannulation on their hand, and after a few days, you can see signs of inflammation over there. This is called as thrombophlebitis. Most of the time, it is non-infective and it resolves on its own. However, sometimes it may get infected with a bacterial pathogen, then we call it as suppurative thrombophlebitis. The other would be Lemierre syndrome, where there is thrombophlebitis of the jugular vein caused by anaerobic infection. This is a very isolated case, but most importantly, in case of veins, we have thrombophlebitis. Next. This was about the peripheral veins, but as far I think I have already told you in the HAIs, a very important aspect is the central line related infections, where the infection occurs within the central lines, also called as catheter related bloodstream infections, and these are very commonly seen especially in ICU settings. Next important part is the infective conditions of the bloodstream proper. That means where the organisms are commonly found. Now, there will be 2 types. One is called as the primary bloodstream infection. That means over here the pathogenesis of the organisms involves the bloodstream. That is, primary bacteremia is the part of the pathogenic process. Other than this, there could be many other organisms or any organism that may spill into the bloodstream from a local or an isolated site. If we look at the organism causing primary bloodstream infections, the organisms would include typhoidal salmonella causing enteric fever, or Brucella causing brucellosis, Leptospira and Borrelia causing leptospirosis and borreliosis respectively, has a group of bacteria, virulent streptococci, and finally, last but not the least, are the rickettsial infections. Now let us look into another case. Now in this case, a 8-year-old boy was admitted with a 4 days history of fever, headache, vomiting, and abdominal pain. Along with that, the temperature was raised. The blood and urine sample were taken for culture and serology. The urine was urine shows normal results. Blood culture was negative. However, typhoid test was positive. What it indicates is the presence of enteric fever. Many a times we will encounter cases of enteric fever where blood culture comes out to be as negative. So let us look at the enteric fever in a gist. Salmonella can be divided into two types, typhoidal salmonella or non-typhoidal salmonella. Typhoidal salmonella obviously will cause enteric fever, and non-typhoidal salmonella will cause gastroenteritis, very rarely in specific scenario, and can also cause septicemia. Transmission is mainly through the oral route, and if we look at the pathogenesis, the organism first is acquired by the oral route. It enters into the gastrointestinal tract, where through the M cells in the Peyer's pages, it enters into the mucosa. From the mucosa, it will enter into the mesenteric blood vessels and thereby causing what is called as primary bacteremia. Thereafter, this organism will lodge into various organs like liver, bone marrow, or spleen. It will multiply over there and then again cause subsequent bacteria. That is called as the secondary bacteria. From the liver, along with the secretion of the bile, it will enter into the gastrointestinal tract again, and it may cause what is also called as typhoidal ulcers in the intestine. Next. So, what is enteric fever? Enteric fever has an incubation period of 10 to 14 days. The fever will have a step ladder pattern along with other symptoms. Rashes may be seen, but in dark complexion people, rashes may not be appreciated easily. Next. Now coming to diagnosis, the diagnosis will eventually depend on the duration of illness. Again and again, this has been stated. In the first week of illness, serological test will not be very helpful. Rather, if in the first week, that is, if the duration of fever is less than 5 to 7 days, we can go for blood culture, bone marrow culture, or duodenal culture. Bone marrow culture has a higher rate of detection, however, it's a more difficult process, hence, blood culture is commonly preferred. Coming to the second week, if the history of fever is more than 7 days, then we have to go for the serological diagnosis. The most commonly test that is done still today, still relevant, is the Vidal test. And finally, if it is in the third or the fourth week, we have to go for urine or stool culture. Next. So this is a picture in which the organisms have been isolated on DCA or XLD, and I think you can see on DCA we can see pale colonies with large black center, and on XLD we can see red color colonies with small or large dark center. This is due to production of hydrogen sulfide. Next. Now coming to the Vidal test, in Vidal we test for the three antigens, that is the O antigen and the flagellar antigen of typhi, paratyphi A and paratyphi B, and then we compare which one of the following increases or decreases. Now this is how the Vidal tests are reported, where H, and I think you can see over here the TO antigen is tested for. We can see clumps still over here, thereafter no clumps. So the titer comes as 1:160, and similarly when we look at the TH, we can see the clumping occurring till 1:320. So that would be the titer. And coming to interpretation of Vidal test, if both the titers are raised, then we can say the enteric fever is due to Salmonella typhi. If it, in case of TH antibody, we have AH or BH, we can say it is caused by paratyphi A or B. If only TO is raised, that means either it is early in the phase, that is a recent infection. If only TH, that means it is in the later half, that is the TO has already decreased. Now, this is the reason why Vidal test has to be repeated after about 5 days, so that we can get the change of titer. Single titer is of no value. Rather, change of titer is most important. And a very important interpretation of Vidal would be the presence of antibodies against TH, AH, and BH, all three, that can be seen after vaccination. More recent tests like Typhoid, in which the ELISA format is used for detection of IgM or IgG, can be used for detection along with other molecular methods. Some of the patients of endemic fever will end up being carrier. That means they will continuously have the organism in gallbladders, and they can be detected either by culture of stool or urine, or we can detect the VI antigen, that is the, and we can also do epidemiological study by culturing from the sewage for detection of carriers. Now, why detection of carrier is important? Because humans are the only reservoir and the reservoir are the carriers. Now, let us look at another case. A 6-year-old boy came with high-grade fever with chills and rigor for about 3 to 4 times a day. On examination, the patient had a high temperature and a raised heart rate. There was no skin rash, lymphadenopathy or hepatosplenomegaly. The lab results showed leukopenia, only leukopenia. Other parameters were normal. Blood and urine culture showed no signs of infections. The malarial parasite and the immunochromatography test for malaria were also negative. Then, what could be the cause? A detailed history elicited that the boy was in a habit of intake of unpasteurized goat milk. Based on that history, the physicians then tested for antibodies against brucellosis, which came out higher than that is expected. So, this is how brucellosis may also present. Now, coming to brucellosis, this is a zoonotic disease mainly acquired from farm animals, and we have about 4 species. Any of them can infect. Next. The transmission may be either direct, food, or airborne, and it spreads from the local site, causes primary bacteremia, and ends up in all distant organs, including reticuloendothelial cells, and even in the musculoskeletal system. So, the common presentation that is seen is called a classical triad, where we have profuse night sweats along with joint pains and hepatosplenomegaly. Along with that, the presentation may be like that of typhoid-like illness or undulating fever, that is, the fever comes and goes and comes and goes repeatedly. And along with that, I have already told you, the organism spreads into the musculoskeletal system. So, we will have musculoskeletal symptoms like vertebral osteomyelitis, septic arthritis, pain in the joint, fatigue, etc. The best method for diagnosis of brucellosis is get a blood culture done. Now, please remember, this organism grows very slowly. Most of the time, the blood cultures will be reported as negative after 5 days of incubation. However, if you do suspect the patient is having brucellosis, please inform the laboratory beforehand so that the culture is incubated beyond 5 days. Sometimes, the culture may even take up to 30 days. So, it is your responsibility to intimate the laboratory that this could be a patient suspected of having brucellosis, so that the cultures are retained for a minimum period of 30 days. Furthermore, we can also go for serological tests like the standard agglutination test or the 2-markup-to-ethanol test for detection of IgG by ELISA. Another case that occurs very commonly in India, let us look at this case. A 43-year-old male patient presented with the complaints of intermittent fever with chills and rigor for 11 days, along with headache, tiredness, dry mouth. The temperature was raised, and on thorough examination of the body, there was a black colored ulceration on the skin. This is called as a scar. Based on that, when Scrub Typhus IgM was done, tested for, the ELISA results came as positive. So what is this disease? This is also called as Scrub Typhus. This is caused by a rickettsia cause Oriental pseudomonas, and the vector would be trombiculid mud, also called as chiggers. Hence this disease is also called as chiggerosis. Okay. So what is the typical presentation of Scrub Typhus? The presentation would be a classical triad of an eschar, that is a black colored ulceration at the site where the mite has bitten the person. Commonly this is seen on exposed areas like arms or legs. Sometimes it may also be seen in not generally accessed area like the nape of the neck. Furthermore, we will have regional lymphadenopathy based on the type of the area that has been exposed and maculopapular rash. Non-specific complaints like headache, myalgia, GI symptoms may be there. Complications may arise causing encephalitis or interstitial pneumonia. Coming to laboratory diagnosis, the mainstay of diagnosis for this disease is by serological testing. The best method would be to test for ELISA or the newer methods like molecular test where nucleic acid amplification tests are implemented. Earlier, Will Felix test or indirect immunofluorescence test were used, but nowadays ELISA is sufficient. So these are the common examples of organisms which causes primary bacteria. However, some of the organisms may cause what is called as secondary bacteria. That means the focus is elsewhere. Like a patient with pneumonia may end up having sepsis, that is, or bacteria. That is called as secondary bacteria. Potentially all organisms can cause secondary bacteria. However, we commonly see bacteria with Staphylococcus, Streptococci, Meningococci, gram-positive like Brucellosis, Listeria, and almost the common Enterobacteriaceae of the gram-negatives. There are some viruses which cause systemic illness where the virus is commonly found in the blood. These would include HIV, arboviruses like dengue, chikungunya, hemorrhagic viruses like Ebola, Marburg or hantavirus, and viruses like Epstein-Barr virus or cytomegalovirus, which causes infection or inflammation in the whole body, that is, whole systemic inflammation. Among them, let us see one or two cases. First case is a 22-year-old male admitted with 3-day history of high-grade continuous fever with chills and rigor and loose stool. He denied abdominal pain or retroorbital pain. On day 5 of illness, he developed an hematoma at the venipuncture site, and later on his condition deteriorated with rising liver enzymes and decreased platelet counts. Next. Most of the serological test comes negative, but when dengue profile testing was done, I think we can see this chart. Initially on day 1, the dengue NS1 antigen, that is the non-structural one protein on the virus, NS1 antigen came positive. However, on day 1, the IgM and IgG were negative. Later on day 5, we can see IgGM is positive, and on day 29, IgG is positive. So, what would be this diagnosis? Okay. Anything else? What is the result of the IgM and IgG on day 1? It's negative. IgG is negative. That means the person had not didn't had any exposure to the dengue virus previously. So this is a primary dengue fever. Now, why this testing is important? Suppose instead of day 29, the IgG came positive on day 1, what would you say? Secondary dengue infection. Now, why this is important? Let us next. Agetta. Next. So, among the arboviruses in India, some of the infections are common. Like in Togaviridae, we have Chikungunya virus. Next. In Flabby, we have Japanese bee encephalitis virus. In the Flabby group of viruses, we have dengue, KFD, that is the Kayasano forest disease, and Zika virus. Next. In Bunia virus, we have sandfly and Ganjam virus. These diseases are very uncommon or rare. And last, in the rhabdovirus, we have Chandipura virus. This has been named after Chandipur in India. Now, all the arboviruses have been classified whether they cause fever with rash or encephalitis or hemorrhagic fever. Now, dengue is one such virus which can present with all three manifestations. It can present with fever with rash, it can present as encephalitis, it can also present with hemorrhagic manifestations. Now, dengue, I think you have already read, there are 5 serotypes. The 4 serotypes are common, there is a newer 5 serotype. Most important part of the pathogenesis that you should realize, the primary dengue fever is most of the time is uneventful. Why? If we look at the pathogenesis, after the virus enters, it multiplies, and after the exposure, what will happen? The body will start producing antibodies against to that virus. Now, most of these antibodies will be non-specific against the non-structural proteins. Hence, they cannot neutralize the virus. Only a very small fragment of the antibodies will form what is called as neutralizing antibodies. Now, when I say neutralizing antibodies, what do I mean? See, we cannot kill a virus, right? The only thing the antibodies can do is it can render it non-infective. That is, if the antibody binds with the virus cannot enter into another cell. This is called as neutralizing antibody. Now, after the infection, the huge amount of antibodies that are produced, only a very small fragment will form neutralizing antibodies. Now, in this case, if the person gets infected with another strain or another serotype of the virus, what will happen? These antibodies which were produced previously and were non-neutralizing, they will be produced even more. And these antibodies will attach to the virus, and now this virus will enter into the cells. That means these antibodies, instead of neutralizing the virus, is enabling the penetration of the virus into human cells even more. This is called as antibody dependent enhancement. Hence, during the secondary infection, the chances of complications will be higher. Next. This is more commonly seen when the infection is seen by the type 2 serotype followed by type 1. However, it may be seen with any serotype. Now, presentation of dengue will be in 2 facets. The one is called as dengue fever and another will be as severe dengue. The difference only is if we have, what is the criteria for severe dengue? When there is signs of plasma leakage or bleeding or organ involvement, we call it as severe dengue. Next. So, whenever you get a patient with dengue fever, always get the test done both for the antigen and antibody, including IgM and IgG. If the IgG is positive in the early phase of the disease, that means you are looking at a case of a secondary dengue fever. The chances of this patient going into dengue, severe dengue, is much higher. So, you need to monitor that patient even more carefully. So, detection can be done by testing for the NS1 antigen and antibody. The best method would be by the ELISA. Virus isolation, similarly molecular test can also be done. Now let us look at another case like dengue. A 39-year-old female presented with 3 days history of fever, pruritic rash and diffuse arthralgia. She complained of severe pain in the small joint of her hand, wrist, hips and knees, and she had a tender lymphadenopathy in the anterior cervical region. Along with that, there was erytheromatous maculopapular eruption. Dengue test serology for dengue test came negative. However, when tested for chikungunya virus, it came as positive. Next. So this would be a case of chikungunya. Chikungunya is an arboviral disease. The word chikungunya itself means folding up. The disease causes severe musculoskeletal pain and the patients will fold up or curl up because of the pain. So the presentation can be either in the acute or a chronic stage. In the acute stage, the patient presents with arthritis along with maculopapular rashes. In the chronic stage, the patient may recover, however, the joint pain remains. Now, if we have to differentiate between chikungunya and dengue, how can we differentiate? Let us look at the differences. The first is fever. The chikungunya fever is more acute, whereas dengue fever is more gradual. It takes about 5 to 7 days. The polyarthritis is very frequent in case of chikungunya, slightly lesser in duration in case of dengue. A very important part is tenosynovitis. Any idea what is tenosynovitis? Hence, in chikungunya, there will be pain on movement of the joints, even on passive movement of joints. That is generally not seen with dengue fever. Furthermore, the rashes can also differentiate. In chikungunya, the rash will come earlier, and in dengue, the rash comes on later. Furthermore, the rash is maculopapular in case of chikungunya, and in case of dengue, it is more of a petechial. Laboratory diagnosis virus isolation can be done, but it is very laborious. More commonly, we can go for MAC ELISA for detection of antibodies. So till now, we have covered primary bloodstream infections caused by bacteria and viruses. But India being a tropical country, we have many parasitic infections of the bloodstream. The first one is, let us look at this case. I think you can decipher this very easily. A 27-year-old male patient admitted with intermittent high-grade fever with high colored urine and joint pain since 1 month. Has a history of travel to Africa. The spleen hepatomegaly and spleen influx seen on USG, and on peripheral blood smear we can find presence of Plasmodium falciparum. So this will be a case of malaria. Now malaria can be caused by Plasmodium falciparum or vivax or oval malaria, and the fifth is Plasmodium knowlesi. I think you are mostly acquainted with the pathogenesis. The disease is spread by the mosquitoes, by the mosquito biting. Then from the mosquito it will enter into the hepatic stage, pre-erythrocytic cytogony, then the erythrocytic cytogony, then the gametocytic stage, and this cycle will go on. Coming to the complications, the most and the dreaded complication is of cerebral malaria or anemia, black water fever, septicemic malaria, and other systemic involvement like ARDS, respiratory, renal failure, etc. Coming to laboratory diagnosis, the best method of laboratory diagnosis for malaria is still relevant is examination of the peripheral smear. Whenever we are advising for the peripheral smear, we have to look at both the thin smear and the thick smear. The thick smear is for quantification of the parasite and the thin smear is for identification of the parasites. Other tests that can be done is fluorescent testing for the parasite in the blood or quantitative Buffy coat. Or we can go for malarial parasite antigen detection or MBBS testing, where we either look for LDH or aldolase, which is seen for all Plasmodium, or we can look for the histidine rich protein type 2 detection of falciparum. culture and molecular diagnosis can also be done. Another case, a 38-year-old woman presented with intermittent fever, night sweats, weight loss, anorexia, and on examination we have found splenomegaly and pancytopenia. IgRA is negative. Now this feature can also be seen with latent tuberculosis. For detection, we can test it for IgRA, which came out to be negative. Next. Thereafter, infective serological testing was done for all these diseases, including HIV, hepatitis, Brucellosis, and cytomegalovirus and Epstein-Barr virus, which all came negative. Next. Furthermore, as we can see, the spleen is grossly enlarged, that is splenomegaly. Finally, bone marrow aspiration was done, and on Giemsa staining, we can find small particles in the bone marrow aspiration. These are called as LD bodies or Leishmania Donovan bodies. This is a case of visceral Leishmaniasis. Now, visceral Leishmaniasis is caused by Leishmania spread by sandfly or phlegmatitis. Next. The presentation would be in three forms, either visceral Leishmaniasis or cutaneous, or the manifestation of visceral Leishmaniasis after treatment is called as post-Kala-azar dermal Leishmaniasis. So in India, if we look at the agents causing Leishmaniasis, we have the old world and the new world, and among the old world we have the chief pathogen Leishmania donovani, where the visceral Leishmaniasis is seen and the post-Kala-azar dermal manifestations are very common. Next. Regarding the pathogenesis, is very simple. The man acquires the organism from the bite of the sandfly, which discharges the promastigotes, which transform into amastigote. From the blood, it will enter into the reticuloendothelial system. These amastigotes will come out in the blood and again taken up by the sandfly, where it will mature to form the promastigote, and the cycle goes on. Now, typical presentation is seen with a pentad presentation, that is 5 presentations. What is the 5 presentation? Fever, progressive weight loss, hepatosplenomegaly, pancytopenia, and hyperglamaglobulinemia. These are the common 5 presentations. Next. Now, I think you can see in this picture, we have hepatosplenomegaly, then we have hyperpigmented skin changes, and the post-Kala-azar dermal Leishmaniasis, where extensive nodular lesions of the skin on the face is seen. Now, coming to diagnosis, the best method would be to go for the microscopic diagnosis, where the most sensitive is splenic aspirate. However, because of the chances of the bleeding on splenic aspiration, preferred method is to go for the bone marrow aspiration, or we can go for lymph node aspiration, and sometimes if the patient is immune compromised, we can even find these LD bodies in the peripheral blood. On bone marrow aspiration, we can find on Giemsa staining these small particles, also called as LD bodies. Those are the amastigote forms of the parasite. Culture can be done on NNN or Snyder's median, and antibody testing can also be done by ELISA. Last part of the parasite disease would be this case. A 58-year-old man from a rural village presented with chronic swelling of the lower limb, as you can see, and with signs of lymphedema. On palpation, the areas are firm and tender and suggestive of lymphedema. Next. So what is this? This is a case of Elephantiasis or lower limb lymphedema caused due to lymphatic filariasis. Now, lymphatic filariasis is commonly caused by 3 important causes: Buschardia bancrofti, Buschia malayi, and Buschia timori. In India, we can find most cases of Buschardia bancrofti and Buschia malayi. Next. Next. Now, during this infection, the infection is acquired by the mosquito, which during its blood meal will introduce the microfilaria into the blood of the human beings. They will move from the bloodstream into the lymph nodes, where they will mature and to form adult male and female parasite. These male and female parasites will mate, and ultimately give a large number of microfilaria. These microfilaria will be again released into the blood, and another mosquito during its blood meal will take up these microfilaria. So the cycle goes on. Now, liberation of these microfilaria is also time dependent. That is, some diurnal variations can be seen. Like in case of Wucheria and Bujia, that is the most common in India, we can see a nocturnal variation where the microfilaria are released more commonly at the night time. This is an evolutionary change based on the biting habits of the mosquito. Now, coming to the presentation, the incubation period is very long, about 8 to 16 months, and the presentation may be characterized into either lymphatic filariasis or tropical eosinophilia or immune complex mediated manifestations. Based on the timeline, we can have an asymptomatic microfilariatic stage or an acute filariasis stage or chronic filariasis stage. Next. In the asymptomatic stage, what happens is the microfilaria is present in the peripheral blood. However, the patient has got no symptoms whatsoever. But if we look at the lymphatics, mainly by ultrasonographic imaging, we can find the lymphatics are now dilated and tortuous. If the adult worm is seen, we can see what is called as filarial dance sign. That means the adult worm is still viable. Next. The next stage of manifestation is the stage of acute filariasis, where we have high grade fever because of the inflammation of the lymphatics. So, there will be lymphangitis and tender lymphadenopathy along with local edema. Now, this will be a dependent edema resolving on elevation of the limb. Some skin changes may also occur in the dependent area, but all the changes are reversible. Next. Now, if this process goes on, what will happen? The fever will ultimately subside. Sometimes the adult worm even dies within the lymph nodes. However, the lymphatic drainage becomes occluded. There will be long-standing lymphedema and it will not resolve even on elevation or on rest. Furthermore, there will be gross skin changes on the skin of the dependent area. Sometimes when this large lower limb becomes large with the lymphedema, we call it as Elephantiasis. That means the limb resembles that of an elephant. Other manifestation could be presence of hydrocele or chyluria. Another uncommon manifestation that can be seen is called as tropical pulmonary eosinophilia. What happens over here, because in patients coming from areas where filariasis is endemic, they have a higher immune tolerance. So when the microfilaria is released into the blood, those microfilaria are filtered within the pulmonary capillaries and killed over there. This leads to a pulmonary manifestation, pulmonary allergic manifestation. People will complain of cough, repeated cough, not resolving to other conditions. This is called as tropical pulmonary eosinophilia. If we look at the blood investigation, we can find raised immunoglobulin E in these patients. Next. Last but not the least, presence of microfilaria will also trigger the immune response. This immune response may lead to deposition of the antibodies and the complement complexes and various organs like kidneys or the joints, leading to nephrotic syndrome or arthritis. Next. Coming to diagnosis, the best method of diagnosis would be to identify the microfilaria in the blood. The preferable time of taking the blood would be at the night, or we can even do what is called as the provocation test. We can give DEC, which will provoke the microfilaria to come out from the lymph nodes into the blood, and subsequently testing on the blood, we can find microfilaria. This is the picture we can see on thick blood smears, the microfilaria is present. We can also differentiate between Wucheria and Bujia based on the characters of the microfilaria. Other testing that can be done is we can test for the antigen like the OG43C antigen for detection or antibody. Imaging studies like ultrasonography can be done on the lymph nodes, and molecular methods can also be Done. So these are the three main important parasites causing primary bloodstream infections. Fungal infections can also be seen, very commonly seen with Candida, more commonly Candida albicans and other non-albicans species, and sometimes rarely by other fungus like Histoplasma, Blastomyces or Coccidioides. Next. The last but not the least part that I want to highlight on, however the organism may reach the bloodstream, whether directly affecting the heart or the vessels, or primary bloodstream infection, or secondary after a localized infection like a pneumonia or a urinary tract infection or an abscess. What it leads to is called as sepsis. Now, what is sepsis? Sepsis is a clinical definition where it is characterized by a life-threatening organ dysfunction due to dysregulated host response to infection. Having said that, sepsis can be infective, can be non-infective. What is important is that we need to detect this condition early so as to prevent the patient going into what is called as septic shock. What is septic shock? This is the subset of sepsis where there is profound circulatory, cellular and metabolic abnormalities which leads to increase in mortality. Next. Now, this is very important, how to detect this. The detection can be done in the intensive care setting with the use of what is called as sepsis organ failure assessment or SOFA criteria. If we look at the criteria, there are some specific parameters like PaO2 by FiO2 and various laboratory parameters. Now, these parameters can be easily seen or can be easily detected in the intensive care setting. However, in non-intensive care settings, these parameters may not be assessed. For that, we have what is called as the qSOFA score or quick sepsis organ failure assessment. This is important because, say, in outpatient or non-intensive care unit setting, you need to assess. What do you need to assess? First is whether the patient's mentation is normal or not. If the patient is confused, drowsy, disoriented, what is the respiratory rate? Higher respiratory rate or extremely depressed respiratory rate would indicate sepsis. And the systolic blood pressure. Any systolic blood pressure less than 100 milligram will indicate possibly the patient is in sepsis. So what to do? Immediately admit the patient in intensive care setting. Resuscitate the patient and put on agents like antimicrobial agents empirically and investigate extensively to find out the cause of the sepsis. Next. Many a times, even after doing everything, the patient may deteriorate, and then we call it as septic shock. So, what is the criteria? The criteria, there are two important criteria. First is need of vasopressors to maintain the mean arterial blood pressure of greater than 65 millimeter of mercury. That is, if you ever visit the intensive care unit, you will find the patients on central line, and from the central line, the mean arterial blood pressure is monitored. Now, if the patient is in need of vasopressors, I think you have already been taught vasopressors, right? So, what does vasopressor do? Exactly. So, if the patient is still in need of vasopressor, that means there is circulatory collapse. So, if the vasopressor is withdrawn, the patient will collapse. That is the first criteria. The second criteria is elevated serum lactate, more than 2 millimole per liter, despite fluid resuscitation. What does this indicate? When does the serum lactate levels increase? When there is anaerobic metabolism in the peripheral tissue. That means the blood is not able to provide oxygen to the peripheral tissues. Now, this can happen in many states. For example, in hard exercise. But what happens over there? After the patient is rehydrated or resuscitated, that lactate levels will go down. However, in these patients, if in spite fluid therapy, the lactate levels are still high, that means there is inadequate perfusion at the cellular level. If these two criteria are satisfied, then we can say the patient is in septic shock. Okay. So the goal is to prevent the patient to go from sepsis to septic shock, and if somebody does go in, to detect the septic shock as early as possible, because patients in septic shock have a higher mortality rate.